call the meeting to order. We're here today to have a hearing on Senate Bill 2484, which deals with pharmacy benefit managers. And then we have a few items on the agenda that we'll take up for consideration later on. At this point, I'll ask the secretary to call the roll.
Ryan, Parker, Barnett, Blackman, Blackwell, Blunt, Kaufman, DeBar, Fillingane, Frazier, Harkins, Hobson, Horn, McMahon, Parks, Polk, Tate, Wiggins.
Just in general terms, the proponents of the bill who Mr. Dozier has got organized for us, I think we'll hear from them for about 10 minutes. And then there are those who I think have issues with the bill. They have about 15 minutes from them. And then Mr. Dozier can come back, or his group can come back for another 5 minutes. I think it would be well if members of the committee during this presentation sort of limited questions to clarification points or yes and no answers or short things like that. And then after we've had those presentations, members can address questions that are be more lengthy to anybody, and we've got everybody here so everybody can respond. And I hope that by proceeding in that manner, we can sort of have what amounts to a discussion of the various provisions of the bill. Having said that, Mr. Dozier, if your folks are ready to go, we'll hear from them.
Thank you. Thank you, Mr. Chairman. Members, Robert Dozier with the Mississippi Independent Pharmacies Association, Executive Director. Senate Bill 2484 has been filed. Senator Rita Parks is lead author on that bill, and it is the Pharmacy Benefit Prompt Pay Act. That act has been on the books since 2006. And every so often, we will come back and add legislation to it, change it up a little bit, because the prescription drug world, especially dealing with pharmacy benefit managers and insurance companies, is constantly changing. In today's market, pharmacy's reimbursement is made up of two parts: the cost of the drug and the dispensing fee. That gives you the total reimbursement for the pharmacy's reimbursement. Currently, pharmacies are reimbursed with a reimbursement methodology using average wholesale price, AWP, as the cost of the prescription drug plus a dispensing fee. AWP can be manipulated and inflated by the PBMs and insurance companies, meaning the reimbursement rate they choose to pay may be inaccurate as we know it. In today's market, pharmacies do not have the ability to negotiate their reimbursement rate with PBMs or insurance companies. NADAC was designed by the Centers of Medicare and Medicaid Services to create a national benchmark that is reflective of the prices actually paid by the retail community pharmacies to acquire prescription and over-the-counter outpatient drugs. The Division of Medicaid and 43 other states use NADAC in their reimbursement methodology. We are trying to establish a totally transparent reimbursement methodology, and this new methodology will start to show that the PBMs are the real reason why prescription drug costs are increasing every year. Some people, like the PBMs and the insurance companies, they like to point the finger at the drug manufacturers. Well, I can tell you this, I don't represent the drug manufacturers, but it's not their fault. Now, the PBMs are the one that's driving that up due to an increase in rebate payment that the drug manufacturers have to pay back to the PBMs and the insurance companies, because it's a pay-to-play game. They have to pay the rebate back to these entities to have their drugs on the preferred drug list or formularies. And that rebate money most likely stays with the insurance company and the PBM. The employers and the payers, they don't probably get any of that money. If the pharmacies are reimbursed at NADAC, they will be reimbursed at the cost of the prescription drug. NADAC is a totally transparent number that is set by CMS and can be seen on the CMS website. Mississippi pharmacies are showing you their cost. When is the last time a PBM or an insurance company showed you their cost? If you go to a grocery store today and you buy a gallon of milk, which might cost $7 or $8, do you think that grocery store owner is going to tell you what his cost is? No, he's not. But the pharmacies out here are willing to go to NADAC, which is a transparent number that can be seen on the CMS website for everybody, and they can see what the number is. Insurance companies and PBMs do not want that. It adds transparency to the process. NADAC has been in effect in Mississippi since 2017. Like I said earlier, CMS required all 50 states to move to an actual acquisition cost methodology to provide for a more accurate and transparency in how prescription drug prices are established. NADAC is more resilient, and you can't manipulate it or inflate it compared to AWP. So some pharmacies buy at good rates. Some don't have the ability. If we go to the NADAC, the pharmacies will be able to see what cost is. And if they are buying above NADAC, they then will try to press their wholesaler and do a better job at buying at a cheaper rate. This will help the patient, because the reason is NADAC is based off of national surveys that is conducted by CMS and a national CPA firm, Myers and Stouffer. So as the pharmacies are buying at a better rate, those prices are going to get into the surveys and system, and it's going to start lowering the NADAC price right there. And that in turn goes toward the patients. Now, also, when Mississippi Medicaid went to the NADAC formula, they had to change the dispensing fee. Now, I know a lot of you here in this room have heard about the increase in the dispensing fee. The Medicaid dispensing fee as of today is $11.29. How did we determine $11.29 is the cost to dispense a prescription in this state? Medicaid did a statewide survey to determine that. $11.29 is an average. It might cost some pharmacies more. It might cost some pharmacies less. It is an average right there. So keep in mind, you have to take both components, the price of the drug and the dispensing fee, put them together to get the total reimbursement. But guess what? NADAC, since it cannot be manipulated by the PBMs and the insurance companies, is a lower price compared to the AWP. Prime example, there's a study that was done several years ago. It was done in between the years of 2015 and 2020. It was about 1,200 to roughly 1,500 generic drugs. They looked at the trends, compared those drug costs of NADAC compared to AWP. AWP rose 1%. NADAC dropped the price in that time frame by 44%. I go back, ladies and gentlemen, it dropped the price by 44%. The PBMs and the insurance companies are not going to tell you that. It is a transparent number. You can look at it on the website. Now, I touched base a little bit about the rebates. Drug manufacturers have to pay rebates back to the PBMs and the insurance companies. They collect all of this money. Majority of the time, the payer, the employer group, they don't know about the rebate money. The PBM insurance companies, they pocket it. Okay? Now, the other thing is spread pricing. What is spread pricing? Spread pricing is when the PBM pays the pharmacy a low reimbursement, but they charge the employer group a higher reimbursement. And they keep the difference right there for basically just doing nothing but processing a claim. That's it. In our bill, what we're trying to attempt, one point is reimburse the pharmacies at a fair and adequate, transparent number and reimbursement methodology, NADAC plus 1129, just like the Division of Medicaid here in the state of Mississippi. We're also saying that the PBMs and the insurance companies must report 100% of the rebate money they collect from the drug manufacturers back to the payer and the employer group. That does not benefit us. That helps the employer group and the payer. And then we're also saying we're going to eliminate the spread pricing. Keep in mind, spread pricing is when the PBM pays the pharmacy a low reimbursement. They charge the employer group a higher reimbursement. They keep the difference. We're saying you're going to pay the pharmacies NADAC plus 1129. You cannot charge the employer group more than NADAC plus 1129. So we're putting some stop gaps in there and everything. I also said earlier that in that study, that 5-year study, that 44 generic prices went down under NADAC by 44%. 85% of the prescriptions filled in a retail pharmacy are generic drugs. That's where you're going to see a huge savings, ladies and gentlemen. That's where it's going to come from. I understand the fear the employer groups and the payers have. I do. I get it. Sometimes they don't understand the PBM model. I've had the experience and the pleasure to represent pharmacy in 2 states and on the national level. And anytime there is a PBM bill out there, first thing PBMs say, they go to the employer groups, it's going to raise your cost. It's going to raise your costs. First thing, right out of their mind. Governor Ron DeSantis had a press release 2 weeks ago, I think, talking about making regulatory moves and passing legislation against the PBMs in the state of Florida. Hadn't even drafted the legislation yet, but the PBMs are coming out saying, hey, it's going to cost an average pharmacy, average family in Florida, $800 extra a year. How can they say that if they haven't even seen the legislation yet? So ladies and gentlemen, it's just not Mississippi that the PBMs and the insurance companies try to, I get it. Nobody wants to pay higher healthcare rates. But ask yourself this question right here. It's very simple. If healthcare costs are going up for the employer groups out there and premium costs are going up for those employees and reimbursements are going down for the provider, who's making the money? It's that guy in the middle right there. That's who it is. That's the individual right there. That's who's making the money. Now, this white paper right here by CMS is dated January 23. I want to read something to you just real quick.
Mr. Dozier, you're at about 12 minutes. You can keep going if you like. But,
no, I'll tell you what.
you'll
No,
pay back
I'll be fair, Mr. Chairman, and I'll.
I'm just going to take it away from your other 5.
I know. I'll end it right there, sir.
Okay. Thank you. And I don't know who is going to speak next. I'm under the impression there's been some sort of agreement by the opponents of the bill is what the order of worship will be. Just come on up, have a place at the microphone and introduce yourself, and we'll be happy to hear from you. But we're going to have about 15 minutes now from those who wish to speak against the bill. Go ahead.
Thank you, Mr. Chairman. I'm Lance Mazrov. I'm the Vice President of Human Resources with Ergon here in Jackson. Ergon is a privately held company. We have employees from Iuka to Hattiesburg to Jackson to Vicksburg to Pass Christian. So we do have employees throughout the state of Mississippi. Corporate-wide, we have about 3,000 employees. We have 1,400 in the state of Mississippi. When I looked at this bill, I was a little surprised. I was a little shocked at what it could do to our costs. Using industry standards, 1,400 employees, assume each employee has 2.5 dependents. Each subscriber, each covered person gets 3 prescriptions filled per month, times 12 months, times an increase of $9.29. That's going to cost our company $1,170,540 a year. You were very informative. I have no doubt, Mr. Dozier, you have a very complicated business. I will tell you, we know what our PBM rebates us. We get that every month on our bill. So to say that and I'm not here to defend PBMs, but I am telling you, there are PBMs out there that refund 100% of those drug costs to the group. And those refunds help keep our costs down. Again, I understand that you have a very complicated business. This bill is doing nothing for our employees. It's not increasing their benefits. It's not providing health coverage to the neediest people in our state. What it's doing is increasing the cost of doing business. I don't have employees coming to me saying, increase the cost of my drugs. So I don't know how I'm going to respond to our employees if this passes. But the pie's only so big and the costs will have to be passed on. Thank you, Mr. Chairman.
Thank you. Next.
Thank you, Mr. Chairman and committee, for the opportunity to speak this afternoon. My name is Maury Hull. I'm the Vice President of Human Resources for the Holmack Corporation Companies of Mississippi. We are a privately Mississippi family-owned manufacturing enterprise with 7 independent manufacturing facilities located in Jasper, Harrison, and Montgomery counties. Holmack Corporation is headquartered in Jasper County and Bay Springs, Mississippi. The Holmack companies employ over 900 Mississippians. Next month, we will celebrate our 60th year of manufacturing products in our great state, and we're proud of that. In the 7 world-class manufacturing plants that we have, we specialize in steel fabrications. We provide parts for some of the world's largest original equipment manufacturers, as well as have our own proprietary products that are Mississippi-made, products like Donkey Industrial Forklifts, Pat-Mac refuse trucks, Huber industrial vacuum trucks, and Hammerhead aftermarket truck accessories and bumpers. As a private Mississippi-owned company, we are constantly challenged with the need to continue to provide quality, affordable health care to our employees and to their families. Holmack Corporation must be, and we are very diligent in controlling our health care and our pharmacy costs in order to stay competitive in a global job market that we fight every day. We as an organization have chosen to be self-funded in our health plan as well as our pharmacy plan and all of our benefit offerings. That decision has always been driven by the philosophy that self-managing your healthcare costs, pharmacy and healthcare costs will assure that we can possibly offer as cheap and affordable healthcare to our dependable employees that we have. Holmac is a rural Mississippi company. Our employees that work for us typically, the workers we have don't have, in a lot of cases, have access to spousal, has access to coverage. So they lean heavily on our company to provide very affordable healthcare pharmacy coverage for their families and the needs that they have. So we take that challenge very seriously as a company. Our ability to negotiate pharmacy and medical cost is essential to our self-funded model that we have. Pharmacy costs have surged tremendously in recent years. Everybody's aware of that. Most Americans think and believe that drug costs are unnecessarily expensive. This bill that we're talking about today will add additional cost, will probably increase that dissatisfaction even greater. Prescription drug costs continue to increase year over year, a lot greater than the inflation rate that we have. Prescription drug costs are now the second largest healthcare expense for companies, representing roughly a third of the total healthcare costs that we pay for our employees. A third of that is in pharmacy. A top tier benefit plan is essential to becoming an employer of choice. It gives companies like ours an advantage when we're trying to recruit talent, especially Mississippi talent. It helps us to motivate skilled labor employees is what we live on and help our companies grow. We need to keep those skilled labor employees on the job. Rising pharmacy costs will hinder that advantage that we have. Our ability to negotiate with our PBMs, and we do annually, and we do understand rebates, and we do get all of our rebates and have a very transparent relationship with our PBM. But the ability to negotiate contracts through networks assures us a competitive opportunity to keep those costs as low as we can. We negotiate every year with our PBM these contracts to try to keep the cost as low as we can and advantageous to our employees. And those dispensing fees that's discussed today are exactly a real part of that negotiation. Senate Bill 2484 will be attempting to dictate that fee, eliminating mine and our team's opportunity for negotiation annually. If Senate Bill 2484 passes, it will lead to higher drug costs and ultimately higher costs to our employees. For a private Mississippi company our size that pays on average about 10,000 pharmacy claims a year, our self-funded plan would take on an additional $100,000 in cost to dispense those same drugs again this coming year. Senate Bill 2484's passage would require us to do one of two things. It would require us to increase out-of-pocket costs to our employees, or it would require us to increase insurance premiums, which comes out of our employees' paycheck every week. Holmac Corporation is committed to providing our employees with the best care possible. That includes making sure that they have access to medication that they need and medications that they depend on. We believe it is in the best interest to have the ability, we have the ability to negotiate drug pricing and dispensing fees with our PBMs so we can get the most economical price for our employees. We urge the Mississippi legislature to keep businesses like ours in mind when considering passage of this legislation. Successful Mississippi-owned businesses like us, large or small, that had their genesis in Mississippi and are providing high-paying jobs like manufacturing jobs like we do, we want you to know that we encourage you to always put the protection of those businesses like ours the top of your priority list as you consider legislation. Thank you again for allowing me to share today in your consideration of our concerns. We hope that the legislature will understand and vote against this bill. Thank you.
Thank you. Who's next? If anyone. Are there other people to speak in opposition to the bill? If not, Mr. Dozier, do you want to say a few words? Or it might be just as well if, because they really kept to the time. Why don't we just start taking questions and maybe you'll have an opportunity to essentially rebut during that. Would that work?
That's fine. That's fine with me, Mr. Chairman.
Okay. The members of the committee have questions. If no one else does, I have a question. Mr. Dozier makes the argument that in fact, his legislation will reduce cost for the employers. And those of you who are here on behalf of employers, I don't think so you don't want your cost to go up. I don't think any of us want your cost to go up. But what's wrong with what Mr. Dozier's saying? What's he missing in his presentation? As I understand your argument, is if your bill passes, then what happens is, although the dispensing fee goes up, your bill will bring down the cost of drugs generally, and you will be able to access the rebates, and it will result in lower costs to the employers. What's he got wrong? What's he failing to? Sure. I mean, if you don't mind, come over here so we can all hear you. And I hope I'm not being flip. I'm just trying to find out.
No, I understand.
You obviously look at this differently, so.
Excuse me, I'm sorry. I do understand the question. Again, we get 100% rebate from our PBM. So what this bill is going to do is increase the fixed costs for us from the $2 dispensing fee to the $11.29 dispensing fee. It's not going to do anything on the rebates for us because we already get 100% of the rebates back. We get that every month. It's shown to us how much money we get back on drugs that are prescribed under our plan.
Okay.
Can I ask, am I allowed to ask a question?
Absolutely.
No.
Don't you direct it to me?
And again, I concentrated on the fixed costs, the dispensing fees. But one of the other features in this bill that I passed over because at the time it didn't affect me, but I'm curious. It's my understanding the state employees medical benefits plan is exempted from this. Is there a reason the bill is exempting one medical plan, but not private employers?
Okay, let me ask Mr. Dozier a question. I want to get to the question about the state employers exemption, but it would seem to me that there ought to be somewhere in the world an employer who would come up and say, well, you know, we had this legislation in our state and it worked and our costs are lower. Are those individuals around?
The first state that's done this, a NADAC plus higher dispensing fee, West Virginia. It's been in place for 2 years. Been in place for 2 years. If it were so bad, ladies and gentlemen, wouldn't you think the employer groups and the state legislature in West Virginia would have changed it? I go back to what I was saying earlier about the business groups and the employers being scared. I get it. I understand. I've been representing independent pharmacy 20 plus years. It is a scare tactic every year. Every year you change a period, semicolon, the PBMs, the insurance companies they're going to scare the payers. You have to focus on the total reimbursement methodology. The cost of the drug plus the dispensing fee. I'm not going to deny that we're going up on the dispensing fee. It's there in the bill. The dispensing fee goes up. The cost of the drug drops so much by using NADAC that NADAC offsets the cost, the increase in the dispensing fee. So the total reimbursement is going to go down. Now, how am I going to make money, or my pharmacy is going to make money? We have to be better businessmen and women. We have to look for the better deal out there. We know what NADAC is going to be because NADAC is a transparent number on the CMS website. We can see it. I'm sorry, Mr. Chairman.
No, that's not, I keep saying that, none of us are experts. All we did was win an election. And I think at some point, people are going to get tired of the chairman of public health and welfare saying he doesn't understand public health and welfare. But Mr. Mazeroff knows what he's doing. And so why can't you convince him that you're right? I'm not trying to gauge in personalities, but why haven't you been able to convince the employers that what you're proposing is going to save them money?
Because the employers, from all of them that I've talked to, and I haven't talked to this gentleman, but maybe 10 minutes ago, they're focused on the increase of the dispensing fee. I think you had told me you did the number of employees times 3 prescriptions, maybe, and you did it by $9.29 figure. And that's how you came up with the $1,117,000. Just the increase in the dispensing fee. The number's wrong. I hate to disagree with you.
We can all disagree
But
without
the
being
thing is,
disagreeable.
you have to take the cost of the drug in. NADAC is going to lower the cost of the drug. If NADAC plus a higher dispensing fee is so bad, why hadn't the Division of Medicaid changed it? Why hasn't CMS changed it? Why are there 43, 44 states across the country using NADAC plus a higher dispensing fee in their state Medicaid?
Well, let me just ask the other question. Why is the state employees plan exempt in the legislature?
I thank y'all for asking that question. We passed this, the Pharmacy Prompt Pay Act in 2006, I do believe. Medicaid, the Division of Medicaid and state employees has never been in this act. It has always been about commercial PBMs. Mr. Chairman, you understand way better than I, we have a Medicaid technical amendments bill. That's where we handle all of the Medicaid stuff. We have insurance codes out there. That's where we would handle state employees. We don't have anything out there that can do commercial. That is a typical scare tactic by the PBMs, once again.
Okay. Thank you. Senator Polk, and I've got Senator Horn and then some others, but we'll go to Senator Polk and then I'll make the loop.
Thank you, Mr. Chairman.
And feel free to direct questions to anybody.
Okay. I'm not sure who to ask this to. I'm assuming that both of you gentlemen that spoke are self-insured. Okay. The one group that I haven't heard from are those who have regular insurance, that the insurance company itself has the PBM. And self-insured gets apparently this information back from the PBMs of what their rebates are. Small business, I'm pretty sure, never sees that. And so I would like to hear one day from smaller businesses who are not self-insured to see what their idea about this would be.
We have anybody here who can speak to that? Okay. Senator Horn, you had a question.
Thank you, Mr. Chairman. So if we're going to excuse me, if we're going to make the NADAC costs more consistent and centralized, won't that affect the amount of rebates that PBMs are able to offer?
Repeat the question again, I'm sorry.
You're saying you're trying to get the NADAC price to be fairly uniform, is that correct?
Mhm.
So wouldn't that affect the amount of rebate a PBM is able to offer?
Back to the
Back to
PBM.
the employer.
Back to the employer group.
Yes.
That would be held up in negotiations between the PBM and the employer. Because these gentlemen, they're saying they get the rebate, and I have to trust them right here. And I hope they're truly getting 100% of the rebate money back from the PBM. A lot of companies, like Senator Pope just said, they don't know what the rebate is. They don't know if there is a rebate out there. So some of these smaller companies, they don't know. And so therefore, that's why we're putting that stipulation in there of saying, hey, you've got to report 100% of the rebate money back. Now, these larger employer groups, they're sitting down with their insurance companies, their PBMs, and they're negotiating on these rebates. But for the mom and pop, like Senator Pope was talking about, they don't know about the rebate. So therefore, we need that language in there to help those employers out there.
So currently, can an employer insist on seeing what a PBM's rebate structure is?
And I doubt very seriously if they will see 100% of the rebate, because it all goes back to the contract. Keep in mind, the contract between the PBM and the pharmacy is a non-negotiated contract. They throw it on the table and say, you're going to sign it. If you don't agree to these terms, you're not in the network. So it's all about the contract.
Thank you, Mr. Chairman.
Senator Harkins.
Thank you, Mr. President. Mr. Dozier, you said that right now it's the average wholesale price plus a dispensing fee. What is the dispensing fee right now currently?
It ranges.
So that's fluctuating.
It all depends on what the PBM wants it to be. PBM is in total control.
All right. And then under your proposal, you go to NADAC plus a set fee.
You go to NADAC plus 1129, just like the Medicaid dispensing fee.
Okay. Has there been a study, or not a study, but has there been any effort to say whatever the top 30, 40 drugs are that are prescribed, what the average wholesale price is versus what the NADAC price is, to get a reference as to what the savings are? If you're saying that it's not just the dispensing fee, you have to take the price of the drug in concert with the dispensing fee. Is there a way to say, I mean, I know it depends on, whatever the circumstances are, what drugs are being prescribed, but if it's the 20, 30 most frequently prescribed drugs, what is the average wholesale price versus what is the NADAC price?
I was asked last year to produce that right there, and I did, and the numbers came down. NADAC was cheaper than AWP and such.
It's cheaper, but how much cheaper is it? Is it
Well,
more than
that's where
$11.29?
That's where I'm going to get to the point is on brands, it's going to be cheaper. Brands versus NADAC plus or versus AWP is going to be maybe roughly 5-6% cheaper. Your real savings is going to come in the generics. Keep in mind, I was telling you about the study for about a 5-year. Deflation went down 44% in the generics. That's where the huge savings is going to be. And 85% of the drugs that are dispensed in a retail pharmacy are generics. That's the key.
Okay. So has any company volunteered to run I mean, I don't know if this is even possible, so just bear with me, but run a month of their prescription drug cost to see if there is a savings or if there is an
There are
increase in cost?
companies across the country right now that are partnering with healthcare consultants that have no business affiliation with PBMs or insurance companies. And they are running the comparison right now between NADAC plan, prescription drug plan versus an AWP drug plan. And those studies are coming out saying the NADAC drug plan is cheaper than the AWP drug plan. But the majority of the problems is these consultants that are representing some of these companies are also working for the PBMs as well. So they're kind of double dipping out there. These companies are going to have to hire sophisticated healthcare consultants that have no business with a PBM.
Okay. And my last question, I don't know if I wasn't paying attention because I was trying to write something down, but when Senator Horn asked you, if you go to a NADAC pricing, does that impact the rebate to the company? So like the gentleman said that they get 100% of the rebate back. Well, if the price of the drug is changing, that means that the drug manufacturer obviously is getting a lower rate for the price of the pill if the NADAC price is lower. If I'm selling pills on average wholesale price at $8 a pill and I go to NADAC and it's $6 a pill, that's less. I would assume the rebate would be impacted back to the company. So that cost is also affected in the I guess in the scheme of things. You have to take that in, just like you can't take just the dispensing fee into consideration. You have to take the dispensing fee, the cost of the drug. I guess in this consideration, you'd also have to take the rebate, obviously may change in that scenario, whether or not that's going to come out to increase cost or a savings to a company. Is that possible that the
They're already
rebate may
claiming
change?
they're getting 100% of the rebate. So they know what their rebate is right
But does
now,
the rebate change with NADAC?
but they're negotiating the contract. They need to do a good job in negotiating the contract.
I guess
Wait, I'm sorry. I think I misspoke, but you were saying the rebate from the drug company to the PBM.
I'm talking
correct?
about from the PBM. If he's getting a rebate back from the PBM
The
and
employee.
it's based on a AWP pricing, I would assume the rebate would change if it goes to NADAC. So and if it's part of if they're looking at their bottom line on how much we're getting in rebate, how much are we paying in premiums, all this stuff, if you go to NADAC, does that change? Could that potentially change the rebate back to the company? Because if I'm getting $500,000 a year in rebate on my plan, and all of a sudden we're going to a different pricing formula, I may only get $350,000 back or $300,000 back. I guess what I'm saying is, do you know if the NADAC pricing would also change since it's lower, would it change the rebate potentially?
The manufacturer pays the rebate to the PBM. And
Correct.
I'm just walking through this. That is negotiated between the PBM and the manufacturer, okay? Some companies are claiming they get the rebate back from the PBM. Do they get 100% back? I don't know. Nobody knows really, truly. But here's the thing. And in your scenario right there, they might decrease the rebate if we're decreasing the price of the drug. But they need to look at the overall expense right there.
I agree. I want to take that into. I want
Now
to see if
here's
that's
the
a
deal.
consideration.
If I were in their shoes
Mhm.
and I'm getting $500,000 in rebate, I'd stick to $500,000 at rebate when it comes back to negotiating. No matter if I'm using an AWP model or an ADAC.
That's why they negotiate.
Exactly. And that's the whole problem right there, Senator, is a lot of these companies don't know how to do the negotiating and everything. I have to disagree with this gentleman right here. Once again, he was just multiplying the number of scripts over a course of a year by $9.29. He wasn't looking at the decrease in the NADAC right there.
Mr. Meseroff, Mr. Hall, if y'all want to comment about anything, please do.
Add, Mr. Chairman, that this fee would be a pass-through 100%. Rebate wise, I say this as a company, we negotiate our healthcare cost and the cost we spend for pharmacy contracts and healthcare cost is just as big a part of our business model as buying steel is. And we negotiate steel pricing every day. We don't want the government setting more fixed costs to tell us how much we're going to pay in a commission or a fee on buying steel either. So this is a pass-through from a rebate standpoint. We would care less if we didn't get any rebates. That means we're got low cost and we're not, the rebate's not a carrot to make you want to go to a certain PBM or work with a certain group. Rebates are nice and they do supplement the overall cost of your pharmacy plan. But overall, we're trying to negotiate the best deals we can get for our employees to make sure we can offer affordable health care, just like we negotiate steel pricing and anything else, make sure we can sell product as cheap or high as we can and make as much money as we can.
Well, I think that the rebate is part of the line, it's a line item on your expense,
It
whether
is.
it's either a cost or it's a way to lessen the cost.
It offsets.
It
costs,
offsets
yes,
it. So it's a
does.
factor. And I think what I'm trying to understand is have y'all even, is there a way that y'all even looked at what NADAC runs on your existing, like if you took a month of your,
We personally, I can't say we've compared cost. We feel confident that we have done a very good job of negotiating with our PBMs on pricing that fits our employee demographic and where we are in the state and what pharmacy groups we use throughout Mississippi. So no, we have not done a comparison on cost, but the fee, raising the fee would have no impact on the cost of the drug. It's just an admin fee that we're going to have to pay and pass on to either our employees or to our health plan. So,
well, okay. I don't see how that meshes. If you have NADAC pricing and if what Mr. Dozier is saying is true and the average NADAC price is less for drugs, part of it is what's the cost of the drug, what drug's being prescribed. The NADAC, the pricing as a proportionate cost of the drug varies because if it's $100 drug and it's $11 to dispense it, it's one thing. If it's $2 for the drug and it's $11 to dispense, it's another. But if you don't know what the NADAC pricing is on your formula, how can you say you don't know if you've got a savings or not? I mean, it seems like it may or may not. That's what I'm trying to get to is how do all these components of the formula impact the bottom line? And I don't know if I'm getting it from Mr. Dozier. I don't know if I'm getting it from y'all. I understand it's a
a
convoluted process.
It's
but-
very complicated, but I will say this, I mean, we utilize independent pharmacies all over Mississippi, and our employees do. And I personally know, I hear of cases where our employees take their drug card and get a prescription at an independent pharmacy. I lost $3 on that prescription because the dispensing fee was $2 and my contract cost was a lot better than what he had, probably from a volume standpoint. But I never hear him tell me about the times when he made 300% on a drug that my employee picked up. They never tell me about those. They just tell me about the times they lost money at the point of sale. And I always say, tell me about the times when you really made money on a prescription drug. I don't hear of those very often, but I know they have.
Thank you. I appreciate Mr. Hull remarking that they spend as much time worrying about this as they do about buying steel, because that gives me an opportunity to hold forth about how absurd the situation is in this nation, that employers have to go out and worry about health insurance for their employees. It overstates the price of labor. There is no other nation on the face of the earth where your health care is tied to your place of employment. And it's a never-ending source of frustration. But having said that, Senator Hobson.
Thank you, Mr. Chairman. I'm going to be brief because I know others may want to ask questions, but listening to the questions, and I think there've been some really good questions. Senator Polk kind of got to something that I think we would like to know, and that is about other employers in the state. I recognize that two of our finest employers in the state are sitting here and have presented today, and understand the plight of our pharmacists. But what it makes me wonder, one thing is, is there a model possibly where the Ergons and Holmacks of the world can stay in the situation that they're in, continue to do what they want to do, not interrupt their negotiating power, but for all those other employers that maybe have smaller plans, don't have the purchasing power or the rebate power, rebate negotiating power that our larger companies and self-insurers have, that there be a place for, and I would imagine it's the large number of employers and employees in the state that would be under another plan that would be in the NADAC model that's being presented. Is there a way to have your cake and eat it too, so to speak? Does anybody know the answer to that? Or does it have to be an all or nothing proposition?
It's a good question, and I don't see that we have an answer. I think Senator Wiggins and then Senator Fillingane and then Senator Parker, and we're sort of getting to the point after the three of you, I think we'll be pretty close to winding things up, but Senator Wiggins.
Thank you, Mr. Chairman. Mr. Dozier, so I guess my questions are directed to you, and so you understand, which I think you know, my great grandfather started Wiggins Drug Store. So he was an independent pharmacist and served 40 years in the shipyard community in Jackson County. And so when I look at it, that's what I look at. And so I wanted to ask my first question, which was, you mentioned the exclusion for the state school employees. But isn't it true that Medicaid has its own formulary in the state of Mississippi? And are you saying that these state employees are getting their drugs from the Medicaid? Is that what you're saying?
State employees are getting? what?
Yes. I didn't understand your answer as
Oh,
to why
okay,
they were
okay.
excluded.
Well, we passed this pharmacy prompt pay law back in '06. The Division of Medicaid and state employees has never been in this act right here, never. Medicaid has the technical amendments bill. As you know, you're chairman Medicaid at one time. We can always solve a Medicaid issue there. State employees has never been in this act. We can address the state employees issues, if there are, through the insurance codes that are out there. We did not have a vehicle to address commercial issues. So we had to create this Pharmacy Benefit Prompt Pay Act right here.
Well, okay, the state, Mississippi State and school employees' health insurance is not Medicaid.
That's correct.
So somebody that's enrolled in that plan is getting their drugs.
Medicaid,
I'm asking that. Is that what you're saying? Did they get their drugs from the Medicaid? Because that doesn't make sense to me.
no. Yeah, it's separate. I mean, you have Medicaid where Medicaid beneficiaries go.
Right?
You have your state insurance plan where the state employees go.
Correct.
Two separate entities.
So the state insurance plan, do they not negotiate with somebody to provide drugs for their enrollees?
State insurance is, their PBM plan is covered by CVS Caremark.
Okay, so these state employees have negotiated with a PBM to provide drugs.
That's correct.
Okay, so back to the original question, there's no reason for them to be excluded then.
We
Or
can
they're
put-
being
we-
cherry picked.
We would address that in a tax code. I mean, insurance code right there. Are you trying to put them in there?
No, I'm just saying, it seems to me that it's the
we-
exact same thing as, and I'll use my district as the Ingalls Shipyard, who is certainly a national company who has their own, and they've negotiated to provide drugs to their enrollees.
We have never had Medicaid nor the state employees in this act.
I know, but they do not, but the Mississippi State and school employees' health insurance plan do not get their drugs from Medicaid.
No,
They get
don't.
them through a negotiated agreement with the
From a
PBM.
CVS, from CVS Caremark,
Right.
PBM, contracted
Okay.
PBM.
So you're fine taking them out of this bill.
They've never been in the bill,
They're excluded. Okay, they're
Yeah.
excluded.
them and Medicaid. They've never been in there.
Why are they being why is that PBM being singled out as preferential treatment versus?
Well, it's not being, because CVS Caremark is not, because CVS Caremark represents a number of employer groups out there. Not just the state of Mississippi.
Okay, let me try it another way.
You know,
What puts,
I know where you're going, Senator.
right, why is the plan being separated? Why are they on a different level? Why than anybody else who negotiates with the PBM, and they don't get they get their drugs through a PBM just like everybody else.
We can address the Medicaid issues through the technical.
But it has
amendments
nothing
bill.
to do with Medicaid.
I understand. And we can address the state employees through insurance statute and codes. We did not have any instrument back in '06 to address commercial plans.
Okay, my next question is, and I don't know that we're going to solve this issue because you're saying that the numbers that the gentleman from Ergon quoted, you disagree with those numbers.
1.1 million.
Right, he said 1.7 million for 1,400 Mississippi employees.
Hold on one second, please. Sorry, go ahead,
He
Senator.
said 1,400 employees, 1.7 million. Okay, and they've contracted with their PBM provider.
Mhm.
Okay, and you've said it's all about the contracts. It's all about the contracts. It's all about the negotiating contracts.
On
That's what
their
you said.
end.
Right, correct, on their end. Okay, I think you and I have talked about it as why haven't the independent pharmacists gotten together and negotiated, used the negotiation to get them preferable treatment?
They can't.
Okay,
I mean, you.
or they can't, or they
you-
just,
no,
they
no, no,
don't,
no,
they
no.
won't.
They would love to have the ability, if they had the ability to negotiate with a PBM, I wouldn't be here right now.
Okay, so what concerns me on this whole line is that, as he said, if Ergon has 1,400 people, employees, Ingalls Shipbuilding has 9,000 Mississippi employees and 11,000 total. And he said 1.7 million for 1,400. I can only imagine what the costs to Ingalls. And are you saying that Ingalls, who negotiates contracts with the federal government, with billions in shipbuilding, with billions in defense contracts, don't know how to negotiate a contract over drug prices?
What is their expertise?
They're expert. You don't think that, no,
Building
hold on,
ships,
that you don't,
building ships.
correct.
That's their expertise.
Do I need to
Senator.
tell you what their
And-
payroll is?
No. Let's get
Okay,
back to the
no.
other question.
No, Robert.
No,
Robert.
I mean, I'm answering the question, Senator.
Okay.
Their expertise is building ships.
And you don't
And when
think
it
that they
gets
have
to-
enough
when it
money
gets
to,
to healthcare, what we're seeing in the healthcare world, and Senator Walter Michelle and Representative Hank Zuber had hearings this summer. And what several expert witnesses said was that a lot of these large corporations, medium-sized corporations and everything, they don't have the expertise to negotiate good contracts because the PBMs put so many loopholes in these contracts. Now, have we talked about specialty items? PBMs love specialty items. Guess what? In a lot of these contracts, the payers, they don't know about specialty items.
Robert,
because-
I'm sorry to interrupt, but
Go ahead, my
your
friend.
point, you don't think that Ingalls with their payroll has enough money to pay experts to negotiate contracts when they've negotiated contracts for multi-billion-dollar ships detailed? You don't think they have enough
I think
people to be experts in this area when they serve 11,000 employees?
I don't mean to interrupt, but we're getting close to time. And I think Senator Wiggins' point is obviously Ingalls can hire anybody they want to advise them. And I think Mr. Dozier's point is it's a lot easier to build an aircraft carrier than it is to figure out drug pricing. Senator Fillingate.
Well-
Senator Fillingate.
Well, Mr. Chairman, if I may just finish, I think it's the contract and the negotiation point that I'm making, that these companies like Ingalls have the expertise to do that, and we would be involving ourselves in the middle of that.
Senator,
I understand your position is obviously they do, and Mr. Dozier says, oh, no, they don't. Senator Fillingham.
Thank you, Mr. Chairman. I'll definitely try to be brief. It seems to me, based on some of the really great questions that Senators Wiggins and Polk and Hobson have raised, it appears to me that there are certain companies within the state that are large enough and sophisticated enough to self-insure. And if they're here testifying today, which obviously they are, that they feel like they can get a better deal with their self-negotiating situation than the vast number of other small and medium businesses in Mississippi who cannot afford to do so. Perhaps the parties need to think about a tiered system where those who are self-insured could be exempt from this provision of the bill and continue on doing as they wish to do, but everyone else could get the benefit of the lower drug prices. That's just some food for thought from my point of view. Thanks.
Senator Parker, for our closing round of questions.
Thank you. That was actually what I was going to lead to, but I guess I'll start with that. To Senator Fillingane's point, I'm probably a lot like Senator Polk. I'd call myself a moderate employer. The way it works for me is every year, we have a group of options that come to us, and we have to make a selection on what those options would be. And for me, there's never any selection of, the PBM or rebate or anything that comes back to me. It's just, what is our copay going to be for our doctor visits? What is our copay going to be for our prescriptions? How many different tiers are now going to be in the pharmacy tiers and those kind of things. And what I'm learning from this discussion is that at a greater level, there's some rebates and things that are occurring that aren't making it to me. And so what's happened to me this year, to your point, Senator Fillingane, is for the first time ever, I was offered a hybrid model. And this hybrid model is something new to me. We're going to it right now. So instead of being self-funded or just being traditional insurance, kind of fall in between, where I get some advantages from the hybrid model and I get some advantages from bearing some of the risk. But I say all this because the smaller employers like myself, we can't bear the risk of somebody suffering a major health crisis, as a small employer. The larger employers choose to bear that risk. And I go to example from one of our doctors one day. She came in and we had a Medicare patient who was back after a particular surgery. And this patient had chosen to, with their Medicare benefits, not have a drug plan. And so the patient was in there and had some medicine that they needed. And so the doctor came out and she said, well, Mr. Smith is here and he doesn't have the money for his drug plan because he decided not to have a drug plan. I said, well, did you talk to him about that? He said, yeah, he looked at the expense on it. He decided that it would be more expensive for him, or less expensive for him, to not pay the premium and just pay for the drugs when and if he needed the drugs. I said, well, go back in and tell him that this is one of those times. And so I go through this talk to say that, and I understand the self-funded model, when issues like this come up, it kind of, puts you as an employer in a situation where you have to consider, is this one of those times or not, and look at different things. Because what I've found, at least in my community, and I have not heard this in our discussion today, I value the expertise of the pharmacist much better than the cost discussion that we've had today. I've heard everything in the discussion today about the cost of the drug, the cost of the prescription, but I know from pharmacists that I know that it's not like it was before. When pharmacists are filling up to 300, 400 prescriptions a day, they are in a different model right now. They have different pressures on them now than they've ever had. And they're a unique medical profession in the sense that they aren't indexed to things in the same way that other providers are. They basically make their profit off of the profit they get on the product. And when you go to the pharmacy and you see a pharmacist, There's not a copay to see the pharmacist. There's not a copay to have the pharmacist look and see if you're taking 3 drugs that could kill you if they're in combination in the incorrect way. And so as we look and we talk about this, I'd like Robert, to just mention, how valuable our pharmacists are, and do we need to, in a situation like this, in our discussion, do we need to realize as a committee that we need to put a little more value on what the pharmacists are doing in the community, or are pharmacists just a commodity that are just based upon price? So you have any comment on that, Robert, if you understand where I'm going with that commentary?
Look, Senator Parker, I agree with you 100%. Let's take the recent COVID pandemic. When the rest of the world shut down and a lot of people went home, pharmacists stayed. They held the line. They stayed in the retail pharmacies. They made deliveries. They went to the parking lots. They went to the homes. They did whatever it took to take care of their patients. Everybody's talking about the rising cost of healthcare and everything. I understand that from these gentlemen's perspective. I do. But for a provider, pharmacist, doctor, whomever, healthcare, it's not free. And over the years, providers have been, just taking the reimbursement cuts, going down, down, down. And the PBMs and the insurance companies, they are the ones that are making all the money in this. But you're 100% correct. Pharmacists are a very important link in this healthcare chain that we have today. And the COVID pandemic proved that right there.
And I'll just finish with this. If indeed it is for our larger companies an additional expense, could not that company slightly change the copay for the prescription benefit to offset that? I know in my negotiations, we have gone from, copays of $10 for your primary care, $45 for specialists. We've moved up to $50 for primary care and $100 for specialists. And it moves around, but I guess my hope and everything that comes out on this, and again, I'm directing this to the industry people, is that there will be a vehicle that'll allow you to keep your expenses down, and adjust maybe copays if we choose to move this forward, but I guess I'll end with wouldn't you agree, Mr. Chairman, just to.
That is the tradition. That is the traditional ending. So, and that traces its way back at least to Hanen Miller. Mr. Dozier, Mr. Mazeroff, Mr. Hall, is there anything you feel compelled to tell us that we haven't heard yet? Is there anyone that feels there's something we should know that we have overlooked? If not, I want to thank everybody for coming. I want to thank the committee for their patience. I think it's been productive. It does seem to me that two of the things that sort of struck me during the committee hearing is the point that Senator Polk and Senator Hobson are making, which is what is the situation for smaller employers? How do they fit into the picture? And secondly, if this has been going on in West Virginia for 2 years, you'd think we would have people from West Virginia that are just carried away with it and think it's the greatest thing since sliced bread, or people who would tell us it was a disaster. That would be an interesting thing to find out. Procedurally, this committee will meet at 4:30 Monday afternoon. The first item on the agenda will be this bill. I intend to entertain a motion on the bill and any amendments or subsidiary motions anyone wishes to make. And again, thank you all. We now go to Senate Bill 2282, the automatic repealer on pseudo-veteran. Senator Fillingane, you introduced this bill. Do you know why you did that?
Thank you, Mr. President. This is the pseudo-nephrin bill that we passed a couple of years ago. It currently has a automatic repealer date to January the 1st of 2024. This bill would simply remove the repealer. I think the reason we put a repealer in there originally was because we wanted to make sure that meth labs didn't crop up all over the state after we removed these provisions. And I've talked with the law enforcement community to the MBN director, and they seem, the ones I've spoken with, very happy the way things are working. So hence, they don't feel we need to keep reviewing it every couple of years.
Any debate, questions? You ready to vote? The motion's title sufficient to pass on Senate Bill 2282. All in favor, say aye. Opposed, no. The ayes appear to have it. The ayes have it. We'll report that bill to the Senate. The next bill is Senate Bill 2369, the repealer on the Department of Human Services. Senator Parker moves title sufficient to pass committee sub. We need, with unanimous consent, to make a change, a technical change to the committee sub. The committee sub is to remove the repealer, and there are internal repealers in the bill. The committee sub is just to remove all the repealers. So unless there's objection, we'll correct the committee sub to fix that. This brings forward the existing statutes for the Department of Human Services, basically unchanged from the way they are. The only exception is that in the existing legislation, there are references to I think it's the Division of Child Services, and those provisions are changed, and now there's a reference instead to departments. There are also some stylistic and technical changes, but generally speaking, it's the existing law as it is. Are there questions or debate on the bill? Senator Blunt.
Thank you, Mr. Chairman. Did you say this bill deletes the repealers or just
Yes,
extends?
it would delete the repealer on the Department of Human Services. The committee sub was intended to be drafted that way. And I think what took place is on the last line of the bill, it just simply says the act will take effect, but somehow the repealers remained in it. That may have been a miscommunication between me and the draftsman. But there's, if you wish to offer an amendment to have a repealer, that's certainly in order.
I would ask to be recognized to offer that amendment.
Sure.
I would just to extend the repealer on the department for 4 years.
Okay, do you understand the amendment? Ready to vote on the amendment? All in favor say aye.
Aye.
Opposed, no. It appears the ayes have it. The ayes have it. We'll adopt that amendment. This is 23, so I suppose that'd be 27. Anyone else? Is the motion title sufficient to pass? You ready to vote? All in favor say aye. All opposed, no. The ayes have it, and we'll report that to the full Senate as a committee sub. Senate Bill 2797 deals with the records at the old Mississippi State Asylum. Senator Blunt, you introduced this bill. Do you have any idea why?
Well, this bill is, I'm not going to take that bait.
You don't have to respond.
I'm not going to take that bait, Mr. Chairman. I will say that this bill has been drafted at the request of the University of Mississippi Medical Center, and work closely with them to on the committee sub that's before you. Members of the committee, the state asylum was located on the grounds of what is now the University of Mississippi Medical Center. And you may remember a few years ago, we passed legislation to allow for the cemetery of the old asylum, which is in the northeast corner of the UMC campus, for the cemetery to be exhumed. And they have done a very careful, thoughtful, and meticulous process there, where more than 7,000 graves are in the process of being exhumed. And it's actually garnered a lot of national interest. There's a website dedicated to this, to the Asylum Hill Project. And they're in the process of exhuming those bodies now. The bill that is before us does a few things. First, it transfers the medical records that that go with the bodies from the state hospital to the University of Mississippi Medical Center as part of the Asylum Hill Oversight Committee. It also establishes a process which the university is already undertaking to attempt to contact and notify the families of people who were interred there. They don't have records for everybody, and after folks were discharged, it may not be possible to locate those people, but they're making every effort to do that. I want to emphasize that there were people who were in the asylum who were there for reasons that we would not consider to be mental illness today. And so that shouldn't be a stigma on anybody there, but the records are going to be transferred. The people are going to be notified if they can be found. The federal law, HIPAA, protects the privacy of those records for 50 years after a person has died. So what the bill says is it maintains that HIPAA standard where none of those records are available to anybody for 50 years after that person has died. And then after that 50-year period has passed, it allows for those records, after any personal identifying information has been removed, to be part of the Asylum Hill project so that they can be associated with the bodies and studied if the descendants choose not to exercise their right to opt out. They have that right to opt out if they choose to do that. So HIPAA would control for all these records. And then after 50 years after a person's death, those records may be associated with the body and transferred to the medical center. So that's a brief explanation of the bill, Mr. Chairman. I'll be happy to answer any questions.
Are there questions? The debate is Senator Blunt moves title sufficient to pass. Are you ready to vote? All in favor say aye. Opposed, no. The ayes appear to have it. The ayes have it. We'll report that to the Senate. Senate Bill 2817 deals with legislation concerning the Burn Center. Senator Polk introduced this bill. He moves title sufficient to pass. I will tell the committee that I think we're all familiar with the recent closure of the Burn Center. I had been informed for some time that the University of Mississippi Medical Center was considering establishing a burn center. I honestly did not know until very recently that the Baptist Hospital had employed not merely the director, but also a good number of the employees at the old burn center, in part to keep that group of individuals intact, and that there is a burn center of sorts operating right now at Baptist Hospital. I think there's legislation in the House dealing with that. I'm certainly not in any position to make a decision now, and I don't know that any of us are. I don't know how all of this is going to unfold. I know there are ongoing conversations about it. What this bill would do would simply give us a vehicle on the floor with the appropriate code sections so that if at some point we wanted to do something, we would not be caught by the deadlines. And it would be my intention to have a committee meeting and at least discuss anything substantive about that. But you all know what the deadlines are, and that's where we are. So that's what the bill does, and that's why. Is there debate, questions? Senator Parker.
I guess just one question or comment on your discussion here is the burn center is an extremely important thing that we need to have in our state. And as we're making these decisions, I would hope that we'd make a decision that would allow that to be established with providers who are able to do that immediately and who are in that position instead of having to start from scratch to get there. My understanding is that there are different things that are being considered, and I would hope that as we move forward, we find the opportunity to discuss those resources and availability to reach that need.
I certainly agree. We need to look at the situation and where everything stands, and we just can't do that between now and the deadline. Motion's title sufficient to pass. All in favor say aye. All opposed, no. The ayes appear to have it. The ayes have it. Thank you. I think the hearing was productive. We'll be ready to go at 4:30 Monday, and we'll be taking up a number of other bills, and then we have our standing meeting scheduled for Tuesday. Senator Parker moves, we rise and report. All in favor, aye. Opposed, no. The ayes have it.